I am Ashley with Carolina Breast Friends, and tonight I am introducing Dr. Katie Crisp, and she is doing a presentation tonight on hearing health and the importance of understanding hearing loss. So with that, I would like to turn it over to Dr. Crisp.
Thank you. So my name is Dr. Katie Crisp. I am an audiologist at Audiology and Hearing Services of Charlotte. I have wanted to pursue audiology since I was 16. So I went to Appalachian State, got my bachelor's in science and communication and sciences disorders. And then I went to East Tennessee State right after and got my doctorate in audiology in May of 2021. So I'm here today to talk about the unheard side effects of cancer treatment and managing ototoxicity after said treatment. So a couple things we're going to be discussing today. We're going to be talking about our auditory system, understanding that and ototoxicity, as well as breast cancer treatment, recognizing symptoms, diagnosis and monitoring, management and coping strategies, and then a Q&A after. So first, understanding our auditory system and ototoxicity. So this is our auditory system. You can think of it as three parts. We have our outer ear, that's what you can see. That's where sound is going to travel into our ear canal. That sound is going to cause our eardrum to move. That's called the tympanic membrane. It's as thin as a piece of tissue. So it's really, really delicate. That's why we don't recommend that you use Q-tips. Also in our middle ear system is our ossicular chain. This is actually the tiniest bones in the human body, which is really cool. That ossicular chain is going to cause fluid within our cochlea, so moving into our inner ear, to move. That fluid moves hair cells. That is going to send a response through our auditory nerve. Also part of our inner ear system is our vestibular system. Not a lot of people know that our inner ear also plays a huge role in our balance. So these are some things we'll be discussing today. So the cochlea is our hearing organ. It's a spiral-shaped organ in our inner ear that's responsible for hearing. It's as tiny as a pea, so we're talking about really, really small parts. It contains hair cells that convert sound vibrations into electrical signals to the brain. These hair cells are tonotopically organized throughout the cochlea. So we have the high frequencies at the base, those low frequency sounds at the apex. Something that a lot of people don't realize is we hear with our brains. I cannot say that enough. Our auditory system has two subsystems that help us process sound. We have our orient subsystem that's going to help the brain analyze and process surroundings. The focus subsystem identifies sounds that need to be focused on and filter out the rest. So for example, let's say that you are in bed at night and you hear something in your kitchen. If you have a cat, you might realize that that's likely my cat. But if you feel that someone could be in your home, that subsystem's really going to focus on that. It's going to help us analyze those surroundings. An interesting fact, our brain is scanning our environment 50 times per second. So our system is happening very quickly. These sounds are entering our ear, getting right to our brain, and those sounds are being analyzed very fast. So if you think about it this way, hearing loss equals limited sound perception. That means that your brain is not receiving full sound input, and that can actually result in accelerated brain problems. The Lancet has actually deemed dementia as hearing loss as the #1 modifiable risk factor for dementia. 8% of dementia cases every year are attributed to untreated hearing loss. That might not sound like a lot, but that's actually 800,000 new cases every year. So that's pretty massive. Let's talk about some comorbidities. This is one of my favorite things to discuss. So we'll start at the top left. Even a mild hearing loss can triple your chance of falling. The idea behind that is your cognitive load. You are focused on your auditory processing, so other things fall by the wayside, whether that be balance, cognition, so on. Diabetes, you are 2 times more likely to develop a hearing loss. If you have moderate kidney disease, you are 43 times at increased risk of hearing loss. If you have inadequate blood flow to your inner ear, that can contribute to hearing loss. And we see that with cardiovascular patients. I have a couple patients that actually also have issues with their vision because the whole body is being impacted by this cardiovascular health. We have depression and isolation. So sometimes we have people that will begin to withdraw and isolate themselves from these interactions, like group settings, restaurants, things that they used to enjoy, because they don't want to ask for that repetition, because they feel embarrassed or don't want to become a burden. That's a whole other topic and actually a really big issue. Loneliness is truly a social epidemic. We have ototoxic medications. Of course, we're going to be talking about that today. Cognition, you're 5 times more likely to develop dementia. So tacking that on to what the Lancet found, about that 8%. Something huge within my field is the Achieve study that came out in 2023. We found that hearing interventions slowed down loss of thinking and memory by 48% over 3 years, which is huge. That was supported by the Enhanced study last year. Smokers have a 70% chance of developing a hearing loss. The idea behind that goes behind the cardiovascular health. There's inadequate blood flow to those arteries. Noise exposure, that's something we talk about more often. We used to not talk about that. You know, we were putting cigarette butts in our ears in Vietnam, and we used to never hear the words hearing protection. It's important to know that noise exposure can lead to a permanent hearing loss. So getting into ototoxicity. So ototoxicity is ear poisoning. It refers to a drug or treatment-induced damage to the inner ear. So think of it this way. Oto means ear, toxicity is a poison. Some medications used to treat infections and cancer can cause permanent damage to our auditory system, specifically the inner ear. Going back to our anatomy, that's not only impacting our hearing like so many of us think, it can also impact our balance and our vestibular functions. So those potential side effects, cochlear damage, going back to that little snail-like organ, that can result in hearing loss and or tinnitus. That's due to damage of hair cells. We call that stereocilia in the cochlea, leading to a permanent hearing loss. Then we have vestibular damage resulting in some balance issues. That's disruption to the inner ear's balance system that can cause dizziness, vertigo, and unsteadiness. So how exactly does ototoxicity impact the cochlea? Free radicals. So ototoxic drugs such as cisplatin generate these free radicals, and that's going to cause inflammation and damage to our cochlear structures. These are unstable molecules with unpaired electrons that cause oxidative stress by damaging cells and tissues. Normally, the body is going to neutralize free radicals using antioxidants, but whenever we put ototoxic drugs in the mix, it disrupts this balance. These radicals attack mitochondrial DNA in the hair cells, so that leads to cell death. That's called apoptosis. Free radicals also disrupt ion channels in the inner ear that can impact our fluid balance and the auditory signal transmission. So some common culprits of ototoxicity, some platinum-based chemotherapeutic drugs such as cisplatin and carboplatin. That damage does tend to be dose-dependent and can worsen with repeated exposure. Some aminoglycoside antibiotics. These drugs actually accumulate in the inner ear and can cause this damage following accumulation. We're typically going to use these to treat bacterial infections. Loop diuretics, that's going to treat fluid retention and heart failure. That can cause a temporary loss, but can lead to some permanent damage when combined with some other drugs considered ototoxic. There are other medications, such as anti-malarial drugs and radiation therapy near the ear that can have some ototoxic effects. So breast cancer treatments and ototoxicity. Some chemotherapeutic drugs specifically, we have cisplatin. One study in 23 found that cisplatin-induced ototoxicity occurs in 36% of adult cancer patients. Carboplatin can still lead to hearing impairment, even though it is generally considered less ototoxic than cisplatin. Taxanes, some examples are up there. There was a study done in 2010 that involved 103 breast and ovarian cancer patients treated with taxanes, and they found that nausea and vomiting were common side effects. There were also notable instances of dizziness and tinnitus. Some specific targeted therapies and hormonal treatments, FEGF inhibitors, so some anti-angionetic agents. Proud of myself for saying that one. We have some examples of those medications up here. Those inhibit vascular endothelial growth factor, so that can impair blood flow to the cochlea. We also have some EGFR inhibitors. Those targets are epidermal growth factor receptors. Clearly, these are not words I'm used to saying, which is exposed in cochlear cells. So those inhibitions can lead to altered ion transport and hair cell damage. We also have some SERM and AIs. So estrogen has protective effects on the cochlea, but medications such as tamoxifen blocks estrogen receptors, and aromatis lowers estrogen levels, which may lead to oxidative stress and cochlear damage. Bear with me because I know I definitely butchered the pronunciation on those. Going to radiation therapy. So when we're talking about radiation therapy that is near our ear, our neck, that can cause some vascular damage, leading to reduced blood supply to the cochlea, resulting in sensorineural hearing loss. A sensorineural loss is when the auditory nerve and or sensory hair cells in our cochlea are damaged. Typically, if you see someone with a hearing aid, they have a sensorineural hearing loss. Radiation can cause inflammation and fibrosis to our eustachian tube. So our eustachian tube is huge whenever it comes to equalizing our internal pressure to our external pressure. So that can lead to some middle ear problems. You might, if you're common with kids and having ear infections, they might have tubes. That's because their eustachian tube is more horizontal rather than vertical. It gets more vertical as we get older. So they're more prone to infections just because that fluid really accumulates, and that can cause a conductive hearing loss, essentially fluid behind our eardrum or tympanic membrane. High dose radiation can affect our vestibular cochlear nerve. That can result in hearing loss, tinnitus, or balance problems. Fibrosis and inflammation from radiation can also lead to chronic otitis media. So going back to middle ear problems, like that's what an ear infection is otitis media, tympanic membrane damage, or external ear canal stenosis. So when we're talking about recognizing the symptoms of hearing loss, so some common questions I get: when should I have my hearing evaluated? Most of the time, people are having this gradual decline in hearing, and we don't really know if we're having an issue or not. So some things to look out for. If you have difficulty understanding in noisy environments, this is one of the most common complaints I hear. Background noise like restaurants, large groups, as I mentioned prior. Your brain doesn't do as good of a job at filtering what is speech you want to focus on and what's background noise. So understanding in that noise can be a challenge. You have a high frequency hearing loss, which we will be discussing. You might have some difficulty understanding small children. If you require repetition frequently, you say, huh, what? Sometimes people get into the habit of this, but At times, people truly don't always understand the first time, so they do require frequent repetition. If you perceive others to mumble, it's not always the case that that everyone else is the problem. Sometimes it could just be that everything sounds muffled to you, so you're perceiving others to mumble. You can't understand others on the phone very well, especially accents. We're going to talk a little bit about why that is. If you feel tired after listening for too long, this is something called listening fatigue. This has really been studied in children with hearing loss. They come home from school much more fatigued compared to their normal hearing counterparts. But this can happen at any age. So if you see yourself going to this large group gathering and you're with groups and a noise for quite some time, you might come home a little fatigued because you've been straining to understand all day. You have ringing in the ears. This can be called tinnitus, tinnitus, tomato, tomato. I truly feel there's no wrong way of saying it. I think you just say it however you heard it the first time, and that's okay. So ringing of the ears can be due to other things, but 90% of the time it is due to a hearing loss. If you are 60 years old or older, have a baseline hearing evaluation just to see, what your hearing is and if it's gradually declining over time. Of course, when we're talking about ototoxic medications, we have some recommendations on frequency of how often your hearing should be evaluated. And if you're told your TV is too loud, I am actually a mobile audiologist, so I am in senior living communities often. And I very often am walking down the halls and hear a TV extremely loud, and it takes a lot of self-restraint to not leave one of my business cards. So this is one of my favorite slides, why people lip read. So it could be that you notice, if you have a hearing loss, that you really need to be face to face with someone to understand them. You might rely on their lips a little bit. If we're born with normal hearing, we're not used to relying on visual cues to understand others. But as our hearing is gradually declining over time, our brain is subconsciously relying on these cues, whether it be lip reading, what have you, to get that whole picture. So this is what we call an audiogram. It's how we determine the degree and type of hearing loss someone has. So this top axis is pitch. Left to right, it's low pitch to high pitch. You can think of that as bass to treble keys on a piano. This side is decibels. It goes from 0 dB to 120 dB. On this graph are also the degrees of loss dependent on that decibel. So within this graph, we see what we call a speech banana and some common environmental sounds. So let's say that someone has normal low frequency hearing, but as we get to that 2000 hertz, we slope to a mild loss. Even with a mild high frequency hearing loss, we're missing out on some important speech consonants. So going back to falls, straining, and your processing, your cognitive load being imbalanced. You're straining to understand others. Your other things are falling by the wayside. Going back to small children's voices, they're going to be more high pitched. A lot of the times we do have more of a high frequency loss. That's going to be due to how our cochlea is set up anatomically. Those higher pitches are just more susceptible to damage, such as age throughout time or ototoxic drugs. So most of the time we're going to see a high frequency loss. So we've talked about the hearing, getting into some balance and vestibular symptoms. We could have some vertigo, that's a spinning sensation that can often be triggered by head movement. Disequilibrium, that's unsteady walking. You feel off balance when standing or walking, and you might even stumble frequently. Oscillopsia, that's bouncing vision, so blurred or unstable vision. That can also be a vestibular symptom, as can lightheadedness or a floating sensation. I've also heard the sensation of patients feeling like they're just rocking on a boat, nausea and vomiting, so motion sickness, like especially with sudden head movement. So driving and having to turn your head might make you a little nauseous, so you might not want to drive. So some diagnosis and monitoring. So have a baseline hearing evaluation before you start any ototoxic therapy, whether that be chemotherapy, radiation, or targeted therapy. Have a comprehensive baseline evaluation. What that means is pure tone audiometry. Of course, your provider should look in your ear, perform otoscopy before starting this testing, remove any cerumen if need be, but pure tone audiometry is going back to that little audiogram I just showed you, except we want to include high frequency audiometry. That's because those high frequencies are going to let us know, those ultra high frequencies, I should say, are going to let us know if damage is occurring. Speech testing. So getting a little bit more into your central auditory processing and also cross-checking our pure tone audiometry. Something else, otoacoustic emissions. So sometimes this is actually how newborn babies are tested. That's their newborn hearing screening. It's objective testing. So we're looking at cochlear, so outer hair cell function. If we're losing OAEs, that can indicate an early cochlear damage. So frequency of monitoring. So we have that baseline evaluation before we start treatment. How often should we go back? Ask your physician how often they recommend you have your hearing rechecked. But ultimately, the recommendation goes as so. High-risk patients have that evaluation every 1 to 2 treatment cycles. Low risk every 3 to 4. Radiation therapy patients are going to be before, midway, and post. Platinum-based chemotherapy before each dose. So some management and coping strategies. So talking a little bit about hearing aid styles, just to kind of give you an idea. Let's say that we do have some hearing loss due to ototoxicity. That's okay. We have options for you. So there are various styles when we're talking about hearing aids. You can go a rechargeable option or a disposable battery option. However, not every style is available in a rechargeable option, such as that completely in the canal, or in the ear. It's very dependent on manufacturer, whereas the behind the ear style and the receiver in the canal is rechargeable essentially globally. And then Bluetooth connectivity. These smaller devices don't always have Bluetooth compatibility. That's because the smaller the aid, the less amount of equipment they're able to get in there. So Bluetooth isn't in there always. And then there are various levels of hearing aid technology. So when we're talking about what's right for you, if you were a candidate for hearing aids, you would start with the style, and then you would start with the level of tech. So there are 6 big hearing aid manufacturers. All of them have 4 levels of technology. Essentially, the higher you go in tech, the more assistance you get in background noise, as well as some additional features dependent on the manufacturer. So always talk to an audiologist and see what the right options are for you. Keep in mind your lifestyle. Some of my patients that are a little bit older, I keep in mind dexterity, neuropathy, things like that. But an audiologist can certainly coach you and help you navigate the path of trying to find something that works for you. And when we're talking about hearing aids, we're also talking about brain activity. Going to some neuroplasticity, you use it or you lose it. So over here, we're looking at some brain activity before hearing aids. Then after 1 year of consistent use. Consistent hearing aid use is important. If we're not wearing the hearing aids consistently, our brain is not getting stimulated consistently. Going back to that loss of stimulation and accelerated brain aging. What are some effective communication strategies when we're talking about someone with hearing loss? Even if they wear hearing aids, those hearing aids have a critical distance. You can't be across the home and still expect that person to understand you. It doesn't give them supersonic hearing, even though that would be cool. One thing you'd want to do is get their attention first. If that person that's hard of hearing is focused on another task, watching TV, making dinner, and you ask them a question, they might not understand you the first time because they're not focused on you and they're not facing you. So get their attention first. Going back to that lip reading, face people when you're speaking to them and try to reduce background noise during conversations. You can use closed captioning on TVs. That actually helps me. I get this question a lot. Why is the TV so difficult to understand? How they mix sounds with TV, background noise is a lot louder than it used to be. So it can drown out the speech that you're wanting to hear. Closed captioning can help, of course, dependent on the provider. It's not always that accurate, but it can help. Amplified telephones for better communication. This isn't for everyone, but you might have that person who has a really hard time on the phone and would benefit from some visual cues. So there's such things called caption call phones that actually have what's being said read out in real time. That is actually free thanks to the Americans with Disabilities Act. And also articulate. So articulating your speech is very important. You wouldn't believe it, but I am actually from a very small town in North Carolina called Lenore. My mom sounds like Dolly Parton. My mom's not far from it. But ultimately, I just articulate and really enunciate because of what I do. So articulation is also very important when we're talking about communication strategies and hearing loss. Going back to vestib, so some vestibular support and management. So there is something called VRT, that's vestibular rehabilitation therapy. They're going to use some various exercises to help the brain adapt or compensate for that vestibular loss. When we're talking about our vestibular system, we have three inputs: our vision, our vestibular system, and of course our somatosensory, so our footing. Those are things that a physical therapist can work on to help your brain adapt if you're losing one of those or missing that. Medications for symptom control, assistive devices such as a cane or a walker, even if temporary, it's okay to use that. Some lifestyle adjustments, avoiding sudden head movements, improving lighting, and ensuring proper hydration and nutrition. And that is the end of my presentation. Thank you so much. I appreciate your time.